Hello and welcome to the Weatherford College EMS podcast, where education meets experience and textbooks meet the street. This is episode number 9. I am your host, Tyler Holland, also known as the NIH Man. I'm joined by our resident EMS historian, Adam Parish, and the been there, done that career guru, Samantha Grimsley. Today we're kicking off with a crucial chapter for our second semester paramedic students, Pharmacology. This isn't just drug names and dosages. This is about critical thinking, patient impact, and why what you give matters. We're here to break it down, keep it real, and maybe even have a little fun with it. So, we're going to be talking about paralytics. A little bit scary, right?
Yeah, I think the scariest part about paralytics is what happens if you don't get the tube, or what happens if all things go awry. What do you do next? And so we talked about sedatives in the last one, and to really emphasize why we're giving paralytics, you have to understand the role in which they play. And Adam started to talk about it a little bit with the DSI, RSI, DAI. I gotta say, I came from a area where RSI wasn't really done. It was you waited until somebody took their last breath and then you got the chance to intubate them. And then I came to Texas and all I had ever heard of it was RSI after that. And then I get a little bit more into the field out here in Texas, and then DSI starts coming out, and as I was transitioning into education, then DAI started making its way. And so I think a lot of people confuse what each of them are, and so I think it's really good to go over that before we really jump into the medication aspect of things. And so, DSI, delayed sequence intubation, and it's, first sedate your patient to improve oxygenation and cooperation, and then later we'll paralyze and intubate, right? And so one of the things I was looking up is when do we use this, right? And the biggest thing it said is when the patient gets hypoxic and it's fighting you. So that patient where they're pulling everything off and you're just keep it on and fighting with them. You need some time to set up and get that optimized condition, but it's the common, I can't breathe, can't intubate safely yet. We've got to do that. Does anything ring a bell on that particular situation for you?
Oh yeah. Many times have I dealt with the altered hypoxic patient. And you would think that it would be counterintuitive to take somebody who can't breathe so much and give them something that might be like a CNS depressant, right? However, the opposite is actually is actually true, right? We can really help these guys by giving them a little bit of sedation to calm them down a little bit, make them relax, and then move on with what we need to do with that patient. Now, kind of like Sam was talking about, with DSI, the idea is to minimize that apneic period.
Yep.
And with DSI, we're going to improve their oxygenation prior to the period of apnea. Because, with any of these things, they're going to have a point where they are not breathing. And for them to be able to better, and I hate to use the term, but survive the procedure, essentially, is if we're able to build up their oxygen stores to a point where we know, and I hate to use the big term, but the oxyhemoglobin dissociation curve tells us that we only have a period of time where they're going to be able to compensate without breathing. And if we can get that oxygen store, we can get that built up enough to where they can reasonably go 30 seconds to a minute without taking that breath, then the chances of them being negatively impacted by what we're doing to them, shrinks considerably.
Yeah. I think these are I think if I had to honestly put a number to it, we never were really RSIing. We were actually DSIing more than we were RSIing, because in a sense, RSI, you're not bagging the patient. You're not getting them up to that level, whereas, most of the protocols are you need to bag them up to 90% before you stop, and there's always that threshold where a medical director will say, when they hit this, then you can go ahead and intubate, kind of thing, right? That may take passive oxygenation through a nasal cannula at 15 liters on top of a non-rebreather, or that nasal cannula at 15 liters and a BVM going at the same time. And so I think a lot of the time we were confusing them and saying, oh, well, we'll have to RSI this patient. And realistically, you're over there. They've got a OPA or an MPA in, and they're bagging this patient. Well, realistically, if you're RSIing somebody, yes, you're giving a sedative and you're giving a paralytic, and it's done so quickly because we want to minimize that risk of aspiration, but we're not really bagging these patients. We're getting in, we're making a smooth attempt, we're going for it, and then we're in and we're out kind of thing. So no BVM ventilations are used unless the patient was to desat, then we would maybe have to intervene in that aspect. Now, on the flip side of things, when we talk about drug-assisted intubation, it's less formal. You know, we may be using a sedative and maybe an analgesic, especially if we're not using ketamine. So in that sense, let's say we're going midazolam, we may have to give some fentanyl or something with that. And then we're just intubating without a paralytic.
Yeah, there's a few different things when you start talking DAI. Because so the old school, it used to be PAI.
Yeah, wasn't
which
it
was pharmaceutically assisted intubation?
And we used to have the saying "sucks tube and an apology."
Yeah, yep, sucks and an apology. Yeah, absolutely. But then there was also there's also these other emerging things like there's a COBE, stands for ketamine only breathing intubation, where you actually give a very high dose of ketamine, which will allow your patient to continue breathing, and while they're still breathing, you're tubing them.
Yeah,
you've given them such a high dose of ketamine to where they don't care.
Yeah,
they've lost their gag. They're so dissociated. They're off in la la land, and you can get that tube to where they actually have no apneic period. Now that doesn't always work.
Mm-hmm.
You put the blade in and they start gagging anyway. I mean, you got to take the next step.
Yeah.
Right? But guess what?
Sadly, you just made an attempt.
That's an attempt, but guess what else? You've also given such that high dose of ketamine that the induction agent's on board. Right? So you can go back to pre-oxygenation, here's my paralytic, and go down the DSI route.
Absolutely.
Now, yeah, with RSI though, there is. I can think of only a couple of different instances in which actually, like, that old school mentality of sucks and an apology would ever need to ever be used.
Yeah.
Right? And one obviously would be an anaphylactic reaction, and the other one would be like airway burns.
Mm-hmm.
Right? So you're physically looking at them and they're telling you, my throat is closing. And maybe you take a little looky poo and you see all those...
It's happening.
All that edema and everything in their airway start to swell up. I'm so sorry, bro, that I'm going to have to do this, but we have to do this now, or I'm going to have to cut your neck open.
Mm-hmm.
And I don't know about y'all, but that is not something that I look forward to.
No.
It's not something that your partner is going to look forward to. It's not something your patient is going to look forward to. It's something that needs to be the very last thing. And the step before that is the sucks and apology.
Yep.
Sorry about this, bro, but we're gonna have to do this.
Yeah. So I think one of the things we commonly hear is when we're talking about paralytics for the first time and we're telling them, okay, well, there's two different categories. You've got your depolarizing paralytics and you have your non-depolarizing paralytics. And I think back to like when we were talking about central nervous system and sympathetic nervous system, parasympathetic nervous system, and the neurotransmitters and all of those things, it becomes, well, what are you talking about here? So, you've got your depolarizing paralytic being sucks and your non-depolarizing being your rocuronium and vecuronium. And so if we had to go backwards, succinylcholine is mimicking acetylcholine, hence the cholines at the end of the names, right? Succinylcholine, acetylcholine. And that's binding to those nicotinic receptors at the neuromuscular junction, which is going to cause that continuous depolarization of the cells at the motor end plate, which is going to initially cause, sometimes we see that twitching when we give them medication. What do you call that? The
vesiculation.
There it is. And so the receptor is going to stay depolarized. Those sodium channels can't reset, which then leads to the flaccid paralysis. And I know this is a topic you thoroughly love to talk about on the depolarizing versus non-depolarizing. And then when we go to the other end of the spectrum with the non-depolarizing, these drugs, instead of going with the acetylcholine, they're competing against the acetylcholine for those binding sites. And so they do not activate them, and instead they block the receptor activation without causing, the depolarization, and that results in just a more smooth, flaccid paralysis without those Fasciculations.
Yeah.
That's a mouthful there. So, there's two ends of the spectrum. Do you have anything you want to, like, layman's terms that down to as far as an easier way to remember or when to decide what to go with? I mean, we know that with sucks, there's a lot of contraindications that kind of play into that. And I think that really comes back to the metabolism of the drug and what's happening, because we were talking about, the sodium channels. Really, there's a lot of things that could be activating, when we talk about burns greater than 72 hours, crush injuries, spinal cord injuries, hyperkalemia, malignant hyperthermia. All of these things are going to change our electrolyte imbalance horribly. So where does that play in when we talk about the sodium channels can't reset?
Yeah, so remember when a cell depolarizes, you have the squeeze, right? And so after it squeezes, remember what is happening, right? So where is the sodium and where is the potassium?
In relation to what's going in versus what's going out.
Correct.
Gotcha.
This is a problem, and this is why, these doses of sucks or succinylcholine can, it'll essentially put somebody into hyperkalemia. Okay, and because you're opening all of those channels, you're allowing for all of that potassium to spill out of the cell, and it's going to stay out of the cell. With all of those sodium channels staying open to cause that cell to not depolarize again for that length of time, as long as it's going to stay activated, essentially. You're going to cause all of that potassium to dump. It's going to go into the vasculature, and then we know that when it gets to the heart, and we start saying, okay, so you got a little extra potassium. So what? It's like a banana, right? No, right? You have all of these cells that are open. You have a sudden rush of potassium going through the body, and then you start seeing dysrhythmias and arrhythmias that come from that. And this is why we have to be very careful with it. Now, there's other people that have had burns within the last 24 hours that are experiencing fluid shifts.
The capillary pulmonary.
We can't, that's why we can't give sex to those patients either. Okay, because they're already they've had those fluid shifts already. Their electrolyte imbalances are already present, and then we're going to try to give this to somebody who is going to have the electrolyte balance of essentially somebody that's on dialysis, which is terrible.
Yeah, so you hear all these really negative things already about succinylcholine, and we probably are wondering, why do we have this then? Why do we still use it? And its claim to fame is it's got a really rapid onset, only lasts 7 to 12 minutes. So in those patients that don't quite check those boxes, this is going to be a great option for them. Very short acting. You get a nice window of time to, 7 to 12 minutes is a long time to be paralyzed, right? So it's not like, only 12 minutes? I don't have enough time to intubate. That's plenty of time, guys. So you get the tube, and at least in the hospital setting, it will allow for the assessment of neurological status post-intubation, and it's very beneficial in that regard.
Yeah, I think the biggest thing we have to remember is when we're giving a sedative and then we give a paralytic, it's not going to work right away, right? We've talked about letting things kind of meander. It's always great practice to have somebody work the timer. Like, okay, I'm going to give my sedative. Okay, I'm giving my paralytic. And then waiting that 60 seconds and say, okay, you tell me when I hit 60 seconds, because I think we all get nervous at that point when we push it. We're like, okay, ready, set, go. And then you go to try to open up and it's like not happening, or they're still stiff, or they're rigored in the mouth, or locked down, or they're bucking the second you put it. Now you've just made your attempt, right? As soon as that blade crosses the threshold. And so for that being said, it's like, okay, that's your time to just like slow your breathing and your adrenaline down, relax. I kind of call it my Zen moment, where I'm like, okay, one last mental checklist. Here's my equipment. Here's my backup. Here's everything I need. Ready, set. And then what I like to do in an old-fashioned way is I take a deep breath, and to the point that if I can't hold my breath any longer, then it's time to bag for that patient if I haven't gotten the tube yet. Because if I'm perfusing and I'm breathing on my own, that's saying a lot for somebody who isn't. And so now it's time to make that judgment call, because you see those papers. I've seen medical doctors in there for, a solid minute just trying. It's like, stop. There's only so much, and every second is counting into that, the
oxyhemoglobin dissociation curve.
Swear. And so, now you're going to be chasing your tail to get them right back up again, because right when you start bagging it's not going to happen right away. And so, that's sometimes the key with paralytics. But nonetheless, I went down a rabbit hole of history into these paralytics, and I actually learned that succinylcholine was first discovered in 1906. And
hate to be that guy.
I wish I could say the names of these people. They have some interesting names, but nonetheless, when they were studying the drug, they did it on animals. They were given this thing called curare, and I may be even saying that wrong. It was a poisonous plant extract that paralyzes motor nerves, and so with that, they were able to study the neuromuscular blocking receptors and seeing how the succinylcholine works with that for animals. I swear. But then you look at rock, and it wasn't even brought in until 1994.
Mm-hmm.
And, that's where it got introduced into. So, we know that SUX has a rapid onset and a short duration. And so it kind of makes it ideal. We also know the contraindications to SUX. I mean, it's a big one. What did y'all feel like you went to as your go-to paralytic in the field setting?
I would say it's always been succinylcholine, but whenever I was working, we didn't have the option to paralyze at the time. And that alone kind of dissuades you from taking an airway. Because if you achieve adequate sedation by whatever means, then your airway is now going to be compromised, right? Mm-hmm. By definition, they cannot protect their airway anymore. And the handful of times where we did have somebody with us that could provide a paralytic, it's always been succinylcholine, and I think it's just because of that fast, rapid onset and that 7 to 12 minute window of dissipating as well.
Yeah.
Yeah. Look, SUX. In my experience, SUX is it's a good drug. It's an effective drug. It's easy to calculate. It's easy to to measure.
Yep.
So I haven't really seen it cause a lot of things like malignant hyperthermia or trismus, where it'll freeze your jaw to or cause all those muscles to spasm to where you can't even open the mouth. I haven't seen a whole lot. I'm not discounting that it exists, but to answer your question, I'm a rock guy.
Yeah, I mean, it's kind of nicer because you have a little bit longer of that paralytic period than you get with SUX, but it's often one of the areas that people fail to post-sedate and manage the pain management and the sedative properties, because they get into that mindset of oh, well, they're not moving, they're not out, they're not bucking the tube, nothing of that sort. And if you're doing other things and you're not paying attention to vital signs, it can very easily get away from you. And I hate to say it, but some people don't even realize it's happening until they look at their patient and they see tears coming down their eyes. And you're just like, man, you got to be smart of that. And so when I'm going to perform any kind of airway intervention, I set timers on my phone. A reminder timer. Every 5 minutes I need to assess my patient. I need to look at the vital signs. And so it's constantly going off. And you're like that person who keeps hitting the snooze button on your phone. But nonetheless, in this time and place, it's necessary. You've got to be reassessing these patients. And one of the things I remember when we were flying is we were auditing a chart, and the flight crew double paralyzed a patient. And to this day, I always had it in the back of my head, you do not double paralyze a patient, especially when you're messing with the depolarizing of cells. And then I want to say it was SUX when they did it, because the last thing you want to do is keep opening those floodgates and making it worse and worse and worse. But that's always stuck with me, is never paralyze your patient more than one time in that sense.
Yeah, that's something that you see with a lot of people that have been given the ability to push paralytics for the first time, and they haven't really considered, hey, all right, so I've paralyzed this person, I have gone through my DSI, I have gotten the tube, high fives all around, look at me, look at what I'm doing big boy paramedic things, and then all of a sudden the patient starts to not particularly enjoy that tube.
Yep.
Or you aren't managing them properly. And really that's what it comes down to. But then you'll start seeing the patient move, or you'll see the patient, like you said, cry. And they freak out. They say, well, how do I get this patient to quit moving? I know, I'm going to re-paralyze them.
No.
It's a terrible, terrible idea. When you give a paralytic, you are taking away all compensatory mechanisms. All of them. Every single one of them. They're not going to get it back until that medicine wears off. And with rock, and we're going to talk about VEC as well, but with rocuronium and VEC, they're longer lasting. By the time those drugs wear off, you have done a whole lot of damage to your patient. And this is kind of what they were talking about when they said that shorter duration can be a positive thing.
Yep.
In my experience, though, I like rock because I don't want to depolarize my patient.
Yeah.
I don't want to potentially cause another problem on top of already whatever's going on with my patient. I don't want to cause malignant hyperthermia. I don't want to cause potential for trismus. Because honestly, if that happens, you're going to have to give them rock or VEC anyway.
Yeah.
You're going to have to give a non-depolarizing agent to get on top of the polarizing agent that you just gave, so you can open their mouth to facilitate this intubation. But it does, you're right, it does require a whole lot more thinking, a lot more strategy, a lot more awareness. You have to keep these people sedated. A lot of times, and you're going to hear this several times, where they're going to mention something called a loading dose, and then they're going to have a maintenance strip.
Yep.
And there's, you're going to need to be familiar with your policies and protocols and things like that. And I'm going back from just squarely the paralytic back to the induction agent. We use our induction agent to dissociate and get the patient ready to intubate. Then we use the paralytic to physically facilitate that. A lot of times your policies or your protocols are going to point towards, if you use this, then you can either give, half of your loading dose as another maintenance dose, or you can go from there and have your loading dose, then you can start a drip. And knowing kind of when that needs to happen is very important. A lot of times what I have done in the past, and I feel like has been successful for me, is I have my induction agent on board. I have pre-oxygenated. I have my paralytic on board. As soon as that starts working, I obtain my tube. Once it's verified, that's when I'm going to also give them, like, as soon as it's verified, now let's talk about pain and sedation, right? As soon as that's done, my typical next move is to give them 100 mics or 50 mics of fentanyl. On top of that buys me a little bit more time, and then I start running to, okay, now what else needs to keep them sedated? And remember, when we were talking in the last podcast, a lot of these drugs will potentiate. So we start giving something like, our midazolam or something like that to keep them sedated. And then we're also giving them that fentanyl dose on top of that. That'll really keep them nice and sedated. And you can allow that, depending on how long your transport is, you can go ahead and allow that paralytic to wear off.
Mm-hmm.
And in fact, that's the preference. Also, as we get into things even further, that's also when you really need to be foundationally secure in your vent management and how that whole thing works. And maybe if you're doing this to assist them more than anything, that's when you're going to start making those changes from like an assist control back to like an SIMV or something. It's just different things that you can think about too, right?
Yeah, I think the biggest thing is you have to be thinking about the whole situation when you go to make these attempts, and you're going to give a paralytic, right? So you have to be thinking, okay, we know the standardization has moved from direct laryngoscopy to video. That's shown in studies that there's better success rates there, right? Having a bougie, another great success rate. Making sure you have suction on, already set up, somewhere that's in a reachable mode for you. Making sure that you've got your backup airway already sized and ready to go, that you've directively said, okay, if this happens, then you're doing this. It's kind of like orchestrating a cardiac arrest event, right? Everybody has their roles in doing something, because the second it's pushed, there's no going backwards. It's let it wear off at that point. And if you're giving sucks, awesome, you ain't got a long time to wait. But if you're giving Vec, you could be waiting up to 60 minutes for that paralytic to wear off. And so, everybody has to have that. But then you also have to start thinking, okay, what if like a common thing for us when we were using a video laryngoscope at one of the companies I was at is you would plug it in, but because people were jamming the cord and every single time to the video, it was fraying stuff. And so you would go to give an attempt and you would get like a bad video camera look, and you're like, I can't see anything because it's all distorted, and you're fighting the camera more than you're fighting everything else. You've got other video laryngoscopes where if you can see everything beautifully, you're too deep and you got to pull the video back. And so that takes practice. And a lot of us, I hate to say it, we're kind of egotistical. I don't need to practice. I do it all the time. I could do it in my sleep. Like, no. Yes, there's one thing doing it on a mannequin over and over and over and over, but it's not like we're going into these simulation labs where we can work on patients all day long and be set up for success on all the different fail points that can happen. And that's something we don't consider when we go to grab that paralytic off the shelf and decide, okay, I've got to make this move. What's my backup plan, right? Do you already have your manual laryngoscope so that you can go direct if you have to switch over really quick, knowing that you're going to have to drop something in eventually if you can't get it, right? Or how many of us are performing your Malampatties or your lemon scores or anything of that sort and thinking wider than what it is. I mean, to give a paralytic is to give a paralytic. We know what it's going to do. It's a no-brainer. We're after the same goals, right? It's more or less you have to decide what's the better for the patient on the long scheme of things, also versus the contraindications, versus what are we looking at as side effects and everything of that sort. And so I don't necessarily hate one over the other. I will tell you, I don't have as much experience with VEC because it was on back order for so long that all we had was sucks and rock. And that was what we usually went to. We were always an etomidate and sucks, with post-sedation being Versed and fentanyl. That was just kind of the go-to thing. Then we started making a change over to ketamine and rock and things of that sort. And, one particular patient comes to mind. It was a young patient that said, I'm not getting in that helicopter unless you intubate me. And we're like, bet.
Don't say that to a paramedic.
No problem. And so, she actually physically needed to be flown over to this hospital. And we were like, all right, like, this is going to be the weirdest intubation, right? Like, you don't need it, but I guess we're doing it. And she burned through so much of our medications. I mean, it was one of those situations where I was telling you go 2.5 of Versed, 50 of fentanyl, and then we were burning through that very quickly. And so we went up to 100 mics of fentanyl and 5 of Versed, and you're trying, and it wasn't even more than 2.5, maybe 3 minutes in, she'd be through it already again and bucking at the tube. And I'm like, what is happening here? And so at one point we just ran out of narcs and we had to switch over to ketamine. And we were getting to that point where we were getting a little low on ketamine. And I was like, we might have to make a phone call to a medical director soon for some paralytics, because I don't know what else we're doing here, because I don't know. I don't understand what is happening. Why are we burning through these drugs so much? Mm-hmm. And the only thing we could think of is, like, she's got to be on something that's causing this. Yeah. And that's probably the only time I've ever thought about, like, in the back of my head, scratching my mind going, maybe we need to think about reparalyzing this patient for the all sake of we don't want to die when she starts kicking the pilot here in a second. That's probably the only time I think, and that's where I see a lot of, like, studies of people losing intubation. It's not because they can't do the skill, it's that they can't do it correctly, and they're costing time and money. And it's the same thing of, like, if you don't put on end-tidal waveform and you don't check lung sounds, you're just an idiot, right? Like, the staple of all things that you could do for patient advocacy and care in anything about giving a paralytic or a sedative is what is the aftermath of everything. And so, you see news articles all the time of patients dying because of incompetent paramedicine skills. It's not so much giving the drug, it's the aftermath or the going into it part, right? It's easy just to pull up a medication and push it. Right. So I know we talked more about, like, the task at hand and the skill set, and not so much the drugs. I mean, they're pretty straightforward. Would you not agree with that?
Oh, yeah. What is a paralytic? It paralyzes. End
of story, right?
Yeah.
And I think we all know Stux is quick, Rock is the middleman, Vec is the longest.
Yeah.
Yeah, Rock, is usually about 20 to 30-ish minutes. Vec is more, 30 to 45, maybe an hour. So and with those long-term, if you're going to give something that's going to last a long time, you need to be ready.
Yep.
You need to be ready. To her point, you need to be ready. You need to be foundationally secure in what you're going to do. And at any time, if somebody says, okay, what are we going to do if 10 minutes from now this is what happens? You got to have an answer.
Yeah. Yeah, you got to.
That's where people fall. Yeah. That's where you lose. That's where you get a lot of people that mess up a lot of other people when they really shouldn't have. And to her point, she was talking about equipment. I want to bring that back up a little bit. What I tell everybody is that video laryngoscope. It's my binky.
Yeah.
I love video. But it is a different thing to have a blade in somebody's mouth. So all the action is happening down here. And then to be looking up here where the screen is. Yep. And you're not looking at your hands.
Mm-mm.
Yeah.
And this is something that you need to practice. Mm-hmm. You need to have this idea of, I'm manipulating all this stuff down here, but I'm seeing it on the screen up here. And not only that, but there's also, tricks of that, right? Like there's, what kind of blade are you using? We see this new introduction of the hyperangulated blade,
yeah.
Right? And, making it to where you don't have to, like, torque up on anybody and all these things. I want to talk about the very obvious thing we haven't talked about yet. What happens if they're full of secretions?
Oh, let's go salad maneuver.
Exactly. So there, we have the salad maneuver, and we have our homemade salad.
After getting our butts kicked with the thing.
Yes, absolutely. We have that because that is a real thing. And now, when you're trying, or when you have somebody that's full of all that fluid, you have to then maybe switch to either be very good at salad,
yep,
or you got to switch to direct, right? You have to have command of both of those things. Now, when we start considering, okay, how does this then coincide with everything we're trying to do to our patient? Well, remember, when we introduce a blade into somebody's mouth like that, what else are we doing? We're potentially stimulating the vagus nerve.
Yep.
Oh, yeah.
In a very sick, not breathing, paralyzed patient. And we wonder then why, their heart rate just dropped 20 points or whatever, right? We have to be at the ready for those kinds of things. We have to know that this is what we're doing to our patient. This is how it's working. This is what's going on. And because they're paralyzed, they can't do anything about it.
Yeah.
You've turned all that off, right?
Yeah, I think one of the things that we see a lot now are a lot more advanced airway courses coming out. You know, the best thing you can do for yourself is pass paramedic school, is go into one of those advanced airway classes, 10, 12-hour class. And it's been proven in some of the documents that I've seen that they've seen an increase from maybe 68% now to 75% on first attempt pass. You bring up the good point of knowing your equipment, because you never know if something's going to change at the last minute. I know for me, I was not brought up on video laryngoscope, so the second I started using it, and I had never even seen a bougie until I moved to Texas, and I had already been a paramedic for 4 years at that point. So, trying to learn how now to teach myself, one, to video innovate, and then two, throw in a bougie with that, and having to how does this all work and what works for me? And some people say don't preload, some say, whatever the case may be, deal with that with your medical director. But the formality was the one technique that I was using on this video laryngoscope versus the other one I would go to with the screen that you'd have sitting over here and your patient's over here and you're looking this way and you're right. It's an art. You gotta practice. Just even throwing the mannequin out in the classroom on the floor. Nobody practices intubation on a table anymore. Nobody's intubating table level. You go put it on that ambulance and then decide how much more comfortable it's going to be for me versus Tyler versus you to go intubate the mannequin sitting on the gurney in there. It's going to be so much harder for people who are not my size, because I can actually go sit on the ground if I really wanted to, or I can get into some weird positions and get in there and do what I need to do. But that's not always the case. And then you add the element of let's go bouncing down the road, because if you're telling your partner to pull over and stop, you're delaying getting to the ultimate thing, which is getting to a hospital. And so, at the end of the day, there's a lot of things that can go wrong in this sense. And it's not really always the paralytic's fault. It really comes back to the paramedic. And I know that this is a pharmacology podcast, but there's not a whole lot here to talk about other than the fail points of where it's coming from. Not putting the patient in proper positioning is a big one. Not looking at your patient's anatomy and failing to have a proper backup plan, not selecting the appropriate medications for the right time or a patient, anything of that sort. Not making decisions like that, kind of lagging on it, because time is energy, time is respirations at this point, the brain perfusion going away from your patient. So
yeah, that's a big one that a lot of people struggle with. Even seasoned medics struggle with. When do I pull the trigger?
Yep.
When do I need to make that decision? And again, we will help try to teach you and guide you, but sometimes it's just you walk in, you take a look at your patient, and it just, I sometimes I'll joke around and say, yeah, it's smells like intubation. Mm-hmm. You go in and something just triggers you. You can look at somebody but then there's other people that you're just kind of like, yeah, I don't know, but we'll see. And, and sometimes on those patients, you'll learn. Mm-hmm. You'll get to the point where, it becomes more and more clear as to when to pull that trigger. And it is kind of scary, right? Mm-hmm. And it doesn't need to be taken lightly. But at the same time, it is a very powerful tool that we have. And in the past, there have been some discussion on even the state level as to whether they were going to take that away from us.
Yep.
And so by using these drugs and using our techniques, as long as we are foundationally secure in what we're doing, then we can be successful enough to where we can positively impact our patient outcomes and be able to use this procedure.
Absolutely. Do y'all have anything else you guys want to add into this?
No.
All right. Well, then that's a wrap on this episode of the Weatherford College EMS podcast. Big thanks for tuning in as we kicked off this topic on paralytics, which really just became innovation talk. A topic that can feel intimidating, but we promise it gets clearer with every call and repetition. From Tyler, the NIH man, to Adam, the historian, to myself, the field-tested perspective, we're here to guide you through it every step of the way. Stay curious, ask questions, never stop connecting the dots between meds, the pathophysiology, and the patient. Until next time, stay safe, stay smart, and don't forget, it's not about knowing the drugs, it's about knowing what they do and why. Have a great day, everyone.